Greetings to all the Physio TV viewers. I'm Dr. Franny Nathani. Once again, welcoming you all to one of the most awaited Physio TV sessions, which is actually a treat for all the budding physiotherapists and especially all the neurophysiotherapists. And the topic is Introduction to Motor Learning. And there's something special about our today's session because the session is going to be taken by our very own and esteemed speaker, Dr. Radha Bhattad. So I would take this privilege to introduce Madam. Ma'am is professor and heading the Neurophysiotherapy Department at Sancheti Institute College of Physiotherapy. She is PhD scholar and currently pursuing her PhD in Cognition and Geriatrics. A very warm welcome to you, ma'am. Without any ado, I would request Dr. Radha Bhattad to please take the session ahead.
Thank you, Franny, for your kind introduction. So let's begin with our session. So as Franny ma'am has already told us about that, today we are going to deal with motor learning, Introduction to Motor Learning, Part 1. So basically, I would say motor learning, people tend to get afraid with this topic or are a bit hesitant for it when it comes to motor control, neuroplasticity or motor learning. But I would say as an undergraduate, even I was having this hitch. But when I learned this and when I've experienced this, I have realized that there is nothing to worry about this topic. This is a very, very easy thing. It's more or less about learning, and which is what we are doing since our life, and we will be doing ahead also. So learning, when we talk about motor learning, it is no more less different than the learning that we really do. The only difference or the major difference I would say is here we are talking about how we learn a movement or how we relearn a movement or an action. So that's the major difference that is there. But when we see to the principles or when we are seeing towards the stages of learning and everything, which we will be covering in short or in brief today, so they are almost same. So let's begin with the session. Just a minute, I'll share my slide. Okay, so as we are going to deal with the learning, you can see I have written at the last lifelong learner, and which is the fact of our life that we all are lifelong learners. So today what we are going to cover is concepts, measures, theories, types, and the stages of motor learning. So to begin with, as I said earlier, learning, if we talk about just in normal, learning is what? It's the acquisition of knowledge or skills through study, experience, or being taught is what is learning. And when we come to motor learning, it focuses on skilled or acquired, including the optimal conditioning for learning new motor skills. How a skilled movement is learned or acquired. So when we are dealing about movements or actions, it is about motor learning. So let's see what are the contents or the concepts of motor learning. So as you can see at the top, there's an image of a movie Inside Out, which has very well depicted about learning, how a memory is formed, how a learning takes place. So majorly, these are the four main things that we need to know about motor learning. First, it is a process of acquiring the capacity for skilled action. What is the process or how we can acquire a skill or how we can acquire a movement. Next is learning results from experience or practice. So we all must have experienced this when we were learning in our school days. 2 plus 2 or 2 into 2 is 4 or 2 twos is 4. Initially, we had to practice, and now it is like somebody if asked, what is 2 into 3? We are like 6. We don't need to think about it. We don't need to calculate or say. We can just say it is because we have practiced, we have repeated it many number of times. And there is one more important thing which is written over here is learning results from experience. I hope during our childhood or now many of us have watched either Mowgli or the Lion King movie. If you see Mowgli, he was a human kid, but when he was born and brought up or given the environment of jungle, he had acquired skills which were required to survive in jungle. So because of his experience in the environment there, he learned those skills. So it's simple. Learning can take place either with practice or with experience. The third is learning cannot be measured or observed directly. It is inferred from behavior. So, okay, fine, you have learned, but when we will call ki learning has taken place? Every day we hear a lot many things, or every day the teacher is teaching us. But when it has been asked after some time, or when it is reflected in your behavior or day-to-day life, or if we are saying ki I have taught my patient how to do sit to stand, and in his real life situation, if he is not able to do, we will not say ki the learning has taken place. So it should be inferred from the behavior. And the last is, and which is very important, is there should be relative permanent change in the behavior. If it is not reflected in the behavior, if there's no change in the behavior, learning has not occurred. It's as simple as that. So the main thing that you need to remember is experience or practice. It is inferred from behavior. You cannot count it like that. And it is a relative permanent change that takes place. Coming to the next thing, measures of learning. How would you measure ki learning has taken place or not? So initially the concept was about performance. Ki if you ask a person to do a movement or do a action, and if the patient is able to perform it, means there is that the learning has taken place, the motor learning has been done. But this performance, now it is like performance is not a very accurate measure of learning, because performance can depend on lot many factors. Like if a patient is in fatigue, his performance will deteriorate. If a patient is in anxiety or stressed or depressed, his performance, his movement performance will be affected. So performance is not a very accurate measure of learning. More or less, if we move towards the next measure is retention. So when we want to say that the learning has occurred, it should be retained. It should reflect in behavior. So for example, in a current session, if I'm treating a patient and if I'm giving him some exercise, and if my patient is able to produce that, if I'm teaching reaching activity, and if my patient is able to do it well, and tomorrow when he comes back and I again ask him to reach and he's not able to do that in that accuracy or in that particular manner, so this is not retained. It was that in that particular session, after particular repetition, his performance has definitely improved, but there is no retention. Or we as therapists must have experienced this lot many times, that the relatives or the patient says ki I am able to do it here, but when I go back home I am not able to do. Or the patient relative says ki yahan wo karte hai, ghar jaane ke baad they are not doing it. There is no retention. Not doing it ke liye reason personal bhi ho sakte hai patient ke, but otherwise if we want to speak about retention, if immediate change you are getting or immediate change you are seeing, you are definitely can say the performance has changed, but it has retained or not, you can talk about it or comment on it after successive sessions. If whatever has been taught, if whatever the changes are being done, and if it is reflecting in the patient's activities after few sessions, after few months, or in his day-to-day course, then you can say that there is retention. One more important measure of learning is adaptability. Fine. You taught, there is change in performance, there is retention, but adaptability is very, very important. What does this adaptability exactly means is, you are training in a particular environment to your patient, there he is able to do it, but in his real environment, if he is able to reflect those things, or if there is certain modification, if a person learns to walk in the clinic, सेम अब यहाँ का जो स्पेस है ऐसा ही उसके घर का स्पेस हो जरूरी नहीं है, फ्लोरिंग हो जरूरी नहीं है. So same way, if he can reflect or if he can adapt his behavioral movement skills in varied environment, then we say that there is adaptability or there is transfer of training, or it can be modified as and when required by the patient. So that is about adaptability. So almost if we see performance, retention and adaptability, these are the measures. But if we count on more better measures, if we'll say is retention and adaptability will give us a final call on the motor learning has taken place or not. Because whatever we are treating our patients or whatever we are doing for our patients, if it doesn't reflect in their day-to-day life, if they are not able to do or if they are not able to achieve that independence in their day-to-day life, then there's no sense of treating, or there's no sense of your treatment or the outcome of your treatment basically. So, and that is why we all are dealing or learning this motor learning concept. See, there's one thing called as motor control, which is a process, how this movement is produced or how an action takes place, what is behind scenes of about that particular thing. Learning, after you repeat, after you do things, if it is learned, it will be in your day-to-day activities. So we want that particular thing. So the way we had learned in our life, some things which have been taught, something which we have learned with experience. Now, same things with respect to movement is what we have to follow so that our patients become independent. So if you really want, so there are few pickup points that we should take from all these things, and that should come in our treatment part, which will help our patients regain control over the movement. Next is the theories of motor learning. So as we all know, theories is what this is a concept of क्या होता होगा learning में या कैसे learning होती होंगी. So there are few concepts or school of thoughts which are your theories of motor learning. So the first one is Adams closed loop theory. According to this theories, I'm not going to go in much detail of it. I'll just briefly touch all these three theories. So according to the Adams closed loop theory, in motor learning, sensory feedback from the ongoing movement is compared with the stored memory of the intended movement, which is your perceptual trace. So what exactly this means is, so for example, if you want to go to certain place, you know this is the road which will take me to that certain place. When you 2 or 3 times go to that place by that particular road, this is repetition or practice, you are going by that. So now you remember, okay, this is the route which I have to follow. But while going from this route, there is speed breaker, there is pothole, which now you know, if now the speed breaker is going to come, I will change my speed, again I'll regain my speed. Now there will be a turn, I'll do like this. So these are your perceptual stresses which are built with repetitions. So there are certain nuances or certain things that you take it. So this perceptual stresses and your memory stress forms your learning. So once that is there, then it may be night, it may be day, you are talking and you are driving, but you are aware now when this bumper is going to come, now what I have to do, and you manage it that way. So that is something called as Adams closed loop theory. Focuses on practice leads to formation of perceptual stresses, and which enhances your memory stresses, and thus the learning occurs. So this is the theory. So the takeaway from this theory is you should focus on lot many repetition and practice for your patient. Next is the schema theory. According to this theory, for every particular movement or every particular action, more or less, we have some schema or a blueprint or a map, you can call it as, this things we will be doing to achieve this particular action. That's a scheme or a rule or a concept or relationship which is formed on the basis of experience. Now, things are same, but in varied environment, your reaction to that particular thing is different. Sorry. So for that matter, if I say walking on a normal surface, okay. When I know there is water spill on the floor, I will walk cautiously. The movement is walking only. But when I'm walking at a normal surface and when I'm walking on a surface which is having water spilled on it, it is different. My muscle work is different. My way of walking is different, or the speed is different. So with varied environment, now we know कि अगर ऐसा situation आया तो I'll react like this. If a situation come like this, I'll react like this, or my movements will be like this. So through experience, or through providing lot many variety of experience, the learning occurs. So for example, simple, if we are talking about sitting to standing activity, various heights ka exposure to be given to the patient, then stable surface to unstable surface. The experience, activity is same, it is sit to stand, but the experience that a person gets with the different things is different. So overall, the message with the schema theory, or the take away things that we can reflect in our training, is variety of environmental exposure, or to make adaptability more easy, lot many variations in your protocols, or protocols in the sense with respect to the environment for that particular activity, we need to provide it, so that there is a schema or a map formed for that particular activity. Okay, from foam, if it is an unstable surface, this is how, or this is the strategy of the movement. From stable surface, this is the strategy of the movement. So that schema is formed, and with repetition, it is stored. Next is your ecological theory. Again, here it is, according to this theory, it is identify critical perceptual variability, that is regulatory cues. And when there is this is explore the optimal or most efficient movement for the task, incorporate the relevant perceptual cues and the optimal movement strategy for a specific task. So what best can be a strategy to accomplish this particular task? For example, if I want to lift a glass of water, now if the glass is of steel, if the glass is of paper, if the glass is of plastic, action is the same. Now when I will be given exposure to this variety of the things, I will have my movement strategy for that specific task, for that particular things, and I will build my perceptual cues in that particular way. So after my repetitions with this particular glass, after repetitions with this particular glass, next time, or with few sessions, with few repetitions and everything, when somebody gives me a glass, I can make out how much strength I have to use with my grip to lift this glass. If the same strength, if I lift with a steel glass and with a paper glass or a thin plastic glass, the water will spill. So I know how to grade it because of this perceptual cues, which are now built up with me after lot many repetitions. If for this particular thing, this will be required, or this strategy will be required, this amount of force will be required, this amount of range will be required. So in totality, if we see these theories of learning, they have some limitations. Each one of have their own limitations, which is overcome with some other other theory. So if we overall see, the whole thing is practice, variety of experience, exposure to your patients will and leads to retention and adaptability. So next moving is now the types of motor learning. See, now whatever we are seeing is when we want to treat our patients, what all things we should consider while treating. So we know, because if we say ki I just give 3 or 2 repetitions, the movement will be learned. No. That time you can definitely see a change, and that is the change in the performance, which we already spoke about. So now you can think why we give lot many repetitions, or why should we give lot many repetitions. We have lot many times, we even as a student since our childhood must have repeated few things so that we can learn that particular thing. The same way, that is what we have to do with our patients. We have to give them lot many repetitions, and what is the procedure, how it will be learned, what best can be done so that there is learning, is what whole motor learning, or the concepts, types, theories, strategies, whatever we are going to see, will lead us to that particular way. So coming to the types of motor learning, we have classified majorly. The learning is classified as implicit or explicit learning. Implicit is a non-declarative form of learning. Explicit is a declarative form of learning. When we'll go into details of all this, you'll experience some or the other time in our life, we have gone through this. And we have to pick up which type, what type we have to select for our patient. Sometimes we are selecting one, we are switching, sometimes we are doing mixed things for them. But these are the types that we use so that our patient gets learned, our patient gets that movement learned, or that activity learned, or that skilled movement learned. So implicit is again divided into non-associative, associative, and the procedural learning. We are going to see each one of them in briefly. So when we talk about non-declarative, which is implicit learning, of that non-associative learning. So as it is saying itself, it is non-associative. There's no association. So in this type of learning, a single stimulus, when it is given repeatedly, the nervous system learns about the characteristics of that particular stimulus. So there are two types. One is habituation and one is sensitization. This habituation is very much we must have experienced. People say कि बार बार बोलोगे तो फर्क नहीं पड़ेगा, फिर अब वो ढीठ बन जाएंगे या फिर they will not react to that particular thing. What is that? It is habituation, because same type of stimulus was given repeatedly. There is decrease in the response because of that same type of stimulus giving. There's a habituation which has taken place. Sometimes it is beneficial. Sometimes when you see the same types of response when you are stimulus you are giving and the response rate of your patient is deteriorating, you change the type of stimulus. So as the example is saying here, exercise to treat dizziness in the patients, we give habituation exercises. There it is beneficial because repeatedly giving the same thing, the response जो उन्हें positional change की वजह से dizziness आता था, it gets reduced because habituation has taken place. There it is beneficial. But sometimes it can happen when you are saying your patient, do this, and then the patient is not, because the stimulus was not of that quality or of that particular strength, we are not getting the response and this response is deteriorating. We need to change our stimulus. If our desired thing here is to enhance the response, then we should not go with it. Other one is sensitization. Here, the same type of stimulus, repeated stimulus, the response is enhanced. Sometimes we say our patients, for example, see if you are going anteriorly, and the patient immediately straightens himself. You are going anteriorly, they straighten themselves. So same stimulus was same, that you are going anteriorly, but the response has increased. There is sensitization. Many a times we must have seen our day-to-day life. People are making us more and more aware. What is that awareness? They're just sensitizing us. If you do like this, this will happen. If you do like this, this will happen. So there is sensitization to that particular thing. So with this non-associative form of learning, we have habituation and we have sensitization. So it is we and our clinical decision that we need to take when we are treating patient. We need to take a call what type we are going with. No, I need to change my stimulus type, whether the stimulus is verbal, whether the stimulus is visual, whether the stimulus is tactile, whatever it is, we should take a call there. We need to change the intensity of the stimulus, or this repeated stimulus is not giving me the response which I want, or we want habituation to take place, or we want sensitization to be there. Next is the associative form of learning, which is again a part of your non-declarative learning. So in this, we have two types. One is classical conditioning and one is operant conditioning. So classical conditioning is learn to predict relationship between two stimulus. Patients are more likely to learn if the associations are relevant and meaningful. Fine. If you make your patient well aware, if you will do this movement, you will fall. If you do place it like this, there are chances that you will fall. So don't do this. So now here what you are doing is you are giving a association which is very meaningful. Or other way around, if we want to say our patient, if you want to reach, you will have to bend this much, or you will have to extend this much to reach for this particular distance. Now, to achieve this, you will have to do this. So if you want to lift it, you will have to do this particular action. So you are giving them, if we achieve this, this goal will be achieved. If we achieve, so we have established a relationship between these two things. And when it is meaningful, if I'm treating someone, it is something like if I'm making a elephant learn how to swim, there's no meaning into it. It will be not a relevant movement for them or not meant for them. So they will not pay attention. So it's simple. If the patient choose some exercises, formulate some exercises in such a way that they get transferred into their day-to-day activity, or they resembles their day-to-day activity, so they find it more relevant, there is a connection between them, and they repeat it. So here then what are you trying to do is you are trying to use this classical conditioning form for them. Next is operant conditioning. Again, this is association. So it is very simple. Behavior that are rewarded tends to be repeated. So learn to associate certain response from among many that we have with the consequence. So if you're treating a pediatric patient and if you say, come on, you are doing this, once you stand, you will get this ball, or you will get this chocolate, or you will get this particular thing which he or she was interested in. The way they will do their exercises, the number of times, okay, if you do it 10 times, you will get this, or if you do it 20 times, you will get this. They will easily do it. So what is that? That is operant conditioning of the thing that you are using. Or even in the adult patient or whatever, if we reward it, no, good, very good, you did a good job, you achieved it, or you are doing this correctly. So you reward and you see the patient is repeating the same type of movement. And with repetition, he learns or she learns. So that is what is the operant conditioning. Next is procedural learning. So initially when you are doing this, using such things, either sometimes operant, sometimes rewarding, sometimes linking it, उन्हें थोड़ा सा उनका फायदा बता के, you are linking it, means you are creating associations, sometimes sensitizing, whatever things that you are doing, ultimately what we want is learning to occur. And these are the types in which learning can occur. So you can choose it accordingly, situation wise, patient wise, what form or what type strategy is what you are trying to use. Procedural learning does not require attention, awareness, or other higher cognitive process. One automatically learns the rule for moving, that is movement schema. Learning requires repeating a movement continuously under a variety of situations. So procedural learning is what is the ultimate form. Here you do not require, once initially they will be very precarious. If I am doing sit to stand movement, I have to bend, then I have to stand, then I have to maintain my balance. But after many repetitions, after some sessions, you will see that when you ask them, they easily do that particular thing. That is, the procedural learning has taken place. Now they don't require that much of attention, or they don't require that much of cueings or that much of stimulus to be given to produce a certain movement. The other form of learning was your declarative or the explicit learning. This requires attention. So initially we have seen is implicit learning, and now we are seeing is the explicit learning. In implicit learning, we have gone through declarative, non-declarative, and the procedural learning. Next is your declarative or explicit learning. So this learning or this, when we are using these things or this type of learning method, what we are doing is we make our patient repeat. First, you will do this, then this, then this, and then this. Come on, do it. So you are first giving the declaration or taking the cognitive. That is the reason it is said it requires attention, awareness, and reflection. So as given in the example, first, move to the edge of the chair. Second, I lean forward and stand up. So instructions from the physiotherapist to the patient that first come on the edge, lean forward, and now try to get up. One repetition is done. Again with the second repetition, you again give the cue, verbal cueings आप दे रहे हो, उन्हें बता रहे हो आपको ये चीजें करनी है. Or the patient himself do mental rehearsal. Okay, first I'll do this, and then the movement. Initially, for few days or few repetition, this type is required. And once this declarative learning is transferred into a procedural learning, where you don't require this much of attention or the recalling or repetition of the events. So that is a declarative learning. So we say with practice, this declarative learning is converted or transferred to a procedural or a non-declarative knowledge. So after few repetitions, few sessions, you need not to give that much of cueing or stimulus. The patient does it by himself or herself. Next is your stages of motor learning. This is what is the last thing that we are going to see in this session. So according to the Fitz and Poncer's three-stage model, there are 3 stages in which a learning takes place. So initially what we had seen was what is the motor learning? What are the concepts or the concerns of the motor learning? Next, then we had seen the 3 theories, which was Adam Loop's theory, ecological theory, and the schema theory. Then we have seen the types of learning. What are the types? Next is the stages of motor learning. So the first stage is cognitive stage. Here, lot of attention, lot of cognition of the patient is required to do the movement. So here it is what to do is what the patient is learning over here. So if you see the picture down here, first the girl is trying to just bounce the ball. First, she will bounce with one hand. Then she'll learn to bounce with one hand and moving towards the second hand, switching between the hands. Initially, she has to pay a lot of attention, look at the ball, and then do the particular thing. After that, after some times, then she does not need to look at the ball. Means she has moved from a cognitive stage of learning to associative stage of learning. So here it is. First, she was thinking what is to be done. The focus was what is to be done with lot of attention. When we move towards associative stage, we don't require that much of concentration or that much of attention while performing a movement. Here the thing is how to do the movement. First was what to do, now how to do. So refining of the movement is happening. So that is your associative stage of learning. Next is autonomous stage, means how to succeed. Now you already know how it is to be done, what is to be done, and now with no recall, no retention, now it is like when you say it's in the blood, immediate, no recall, nothing, no practice, and you can do that particular thing. It is your, means you have achieved to your autonomous stage. The same we can go with a car driving example. Initially, if somebody is learning to drive, we have to pay lot much attention. Right side से क्या है, left side से क्या है, पीछे से क्या आ रहा है, then oh am I right, मेरा पैर बराबर है, clutch पे है, now I need to press the clutch, I need to change the gears. So lot much of repetition, recall in our memory and cognition is required, and then we do that particular driving when we are initially. So that stage is your cognitive stage, or when you do is you repeat. Okay, fine, first step what was, handbrake को नीचे करना है, then I need to see neutral है क्या है, I need to press the clutch, then I need to do this particular thing. So it was, you were going with that declarative things, you were recalling and you were doing. So lot means which stage of learning you are in is the cognitive stage. When you are seeing your patient, or when your patient is repeating that particular thing and then trying to do it, or is visualizing himself, okay, fine, I have placed my foot correctly. Oh, okay, fine, I am in the right position. My starting position is good enough. Means that is your cognitive stage. Next come is associative stage. You are driving fine, but certain times you need to pay attention. कभी कभी करते वक्त आपको ये पता ही नहीं था ऐसा हुआ तो क्या करना है, and then you try to do that particular thing. So you are more or less towards your associative stage. You drive, you have learned to drive, but okay, fine, somebody is sitting, you will not pay attention, you will not talk, or you will not do something, change the radio frequency while driving or something like that. So you are in associative stage. Then comes a time, after some time, you drive very smoothly. Whatever the things may be, you can talk and drive, you're on phone, you are changing the radio frequency, you are driving, all at a time. So you are in autonomous stage. Now you don't require to pay attention and do the things. Now it is imbibed and you can do it very easily. So just to summarize the whole thing that we had gone through in the today's session was your concerns or the concepts of motor learning, followed by the theories of motor learning, types of motor learning, and the stages of motor learning. So we have to go through the stages so that learning, motor learning, or the movement or the activity is learned by our patients. So thank you everyone. Hope the session is useful to every one of them. Thank you.
Thank you, Radha ma'am. The talk was indeed very interesting and insightful, and I'm sure it is going to help all our budding physiotherapists. I would want the viewers to know that this was part 1, Introduction to Motor Learning. Stay tuned to watch the part 2 of the same topic. Thank you once again.